Today we're going to look at the information that your doctor should provide to you when she recommends statins, but probably won't. Stay tuned. Your doctor's recommendation to put you on statins is probably based on this treatment guideline. Its short title is Guideline on the Management of Blood Cholesterol. It's really just a statin guideline. 9 out of the 10 recommendations are about when to put somebody on statins. The first one is the only useful one, and that is the one that talks about lifestyle. Unfortunately, it doesn't give any recommendations on what that lifestyle should be, and most doctors just gloss right over it. This particular recommendation, number 7, has a very low bar to clear. Typical total cholesterol in the U.S. is around 190 to 200 milligrams per deciliter, or about 5 to 5.1 millimoles per liter. LDL under 70 in that circumstance is very rare. Certainly the level is going to be above 70 in just about everybody who has a risk level calculated at around 7.5%. For this presentation, I'm going to use statistics from 5 primary prevention and 5 secondary prevention studies, because we're going to look at the information that you should be given if you're in primary prevention and if you're in secondary prevention. In this discussion, I'm going to be using the term heart attack, but really it would be more proper to call it cardiovascular events, or CVEs. Cardiovascular events includes a lot more than just heart attacks. It includes strokes, and it includes certain types of heart failure, but I'm just going to use heart attack because that's more likely to hold our attention. If I say cardiovascular event all the time, not only do I trip over my tongue, it seems like I'm using a euphemism. When I say heart attack, think heart attack, strokes, all the other kinds of cardiovascular problems. So we're going to look at a tale of 2 patients. We're going to look at first Paul. Paul has a 10-year risk factor of 7.5%, and he's in primary prevention. So he is at the minimum threshold for the doctor recommending statins based on these guidelines. I think we should all consider ourselves to be in primary prevention all the time. Doesn't mean we should be on statins. I'm against that in general for primary prevention, but it does mean that we should be following guideline number 1, and that is following a healthy lifestyle in order to avoid having cardiovascular problems. Samuel is a very high-risk patient. He has a 50% 10-year risk, and he's in secondary prevention. He has known cardiovascular disease. He's also going to be told to take a statin. So let's look at some statistics having to do with this. And I'm using 200 patients just because when I tried using 100 patients, I had too many half patients in the statistics here. For every 200 patients with Paul's risk, if they're left untreated, 185 will not have a heart attack and 15 will have a heart attack. If we treat them with statins, statistically, this is what will happen. 188 will not have a heart attack and 12 will have a heart attack. So you'll see that there's not a lot of difference. There is a little difference, and the statins have reduced heart attacks by 3 out of 200. That means there's a 1 in 67 chance, 1.5%, that taking the statin for 10 years will help you avoid a heart attack if you're like Paul. So now let's look at Samuel. For every 200 patients with this risk, well, if untreated, 100 will not have a heart attack in 10 years, and 100 will have a heart attack. Well, that's not good, but it is what it is. That's what it means to have a 50% 10-year risk. If treated with a statin, 109 will not have a heart attack, and 91 will still have a heart attack. So that means that there's a 1 in 22, or a 4.5% chance that taking the statin for 10 years will help Samuel avoid a heart attack. This number, 67 in Paul's case, or 22 in Samuel's case, called the number needed to treat. It's a reflection of how good statin therapy is as a whole. It's the result of 2 characteristics. Statins only prevent some heart attacks, and our prescribing is imprecise. We don't know for sure who will get a heart attack, so we give statins to everyone in the group. That 7.5% risk that Paul has, what that really means is there's a 7.5% chance that he will have a heart attack and a 92.5% chance that he won't have a heart attack. He's not going to have 7.5% of a heart attack. He's either going to have one or not. Now, the reciprocal of the number needed to treat is the absolute risk reduction. And in these cases, it's 1.5% for Paul, and it's 4.5% for Samuel. So if you thought you were getting a lot of protection from the use of statins, keep these numbers in mind. They're not 0. You do get some protection statistically, but just keep in mind how small they really are. Let's go a little further. In Paul's case, Statins do not prevent a heart attack in 4 out of 5 people who are destined to have one. So the statin in his case is 20% effective. Now here we're just talking about people who are destined to have a heart attack. So we're kind of leaving out the 185 people out of 200 who aren't going to have a heart attack with this risk level. In Samuel's case, statins do not prevent a heart attack in 10 out of 11 people destined to have one. In his case, the statin is only 9% effective. In a recent video, I reviewed a case of a patient who was upset with himself because he didn't take statins and he ended up with a heart attack, and he was in this situation where 10 out of 11 times he was going to have the heart attack anyway, so he really shouldn't be kicking himself that hard. He did bypass some theoretical protection here, but it wasn't as much as he seemed to think it was. That 20% or 9%, depending on whether you're primary or secondary prevention, those numbers are the relative risk reduction. It's a measure of how effective the medication itself is in preventing heart attacks for those who will have one if they're untreated. Point is, taking a statin is no guarantee that you're not going to have a heart attack. In fact, it's far more likely than not that if you're destined to have a heart attack, you're still going to have it, even if you take the statin for 10 years. And that's assuming you do nothing else to reduce risk. So now let's look at adverse effects. For every 200 patients, and this applies to both Paul and Samuel, 20 to 100 patients will have adverse effects that will affect their quality of life. Many of these patients will recover after getting off the medication, and only some of them will be permanently damaged by having been on statins. There's fewer than 100 known adverse effects for most statins on the market, so keep that in mind. We don't have good statistics on adverse effects because we don't collect them effectively. There are dozens of recognized adverse effects from statins, but we don't know the true frequencies because they're not collected properly. Many doctors claim that most adverse effects are due to the nocebo effect. They base this opinion on an extremely flawed, very small study with limited applicability to begin with. The doctors have little time to read the study results, so their assessment is from headlines interpreting these results. Some doctors see a study that confirms their biases, and usually it's just a summary, and they use that to try to convince their patients. I see the Samson trial misused constantly in this way. Not only were there flaws in the Samson trial, as I have pointed out, but there are limitations. The Samson trial does not have wide enough applicability that a doctor should just say this applies to every one of their patients. Lifestyle changes, such as reducing blood pressure, quitting smoking, reducing insulin resistance, as applicable. If you don't smoke, then you can't quit, but you know what I mean, and exercising regularly can achieve similar or better reductions than those that you would get from statins. And you can verify some of this by using one of the risk calculators and set some target values. If you have high blood pressure, we'll set a target value of the blood pressure that you would like to be able to get yourself down to through natural means, and I'll get back to that in a moment, but through stress relieving exercises, breathing exercises, changes in diet, whatever it takes to naturally get your blood pressure down. You can see from the risk calculator how much your risk would be reduced. That's assuming that the risk calculator is accurate. I recommend that you use the prevent calculator, because with that one you can also use HbA1c. Getting your HbA1c down is important. If you do decide to take statins, and also to improve your lifestyle, let's keep these things in mind. First of all, statins may actually reduce your blood pressure very slightly. I saw some reports of that. It's small, but it is there. Reducing blood pressure through natural means is much more effective for reducing your risk. And as a matter of fact, a lot of the risk calculators ask whether you're on medication or not. And if you say you are on medication, your risk is a little bit higher than as a result. Being on a medicated 120/80 is probably much healthier than an unmedicated 180/120, but it's not as good as being 120/80 naturally. So there's where that trade-off comes in. Secondly, if you smoke, you can still quit. Statins aren't going to prevent you from quitting smoking. Statins increase insulin resistance, so your dietary changes will be partly counteracted. I see a lot of reports that'll say the number of people who end up getting type 2 diabetes is very small out of the entire population, people who are on statins. What they fail to consider is that if everyone's insulin resistance moves up through the use of statins, only a few will happen to be close enough to the edge of diabetes to go over the edge by taking the statins. I have a video on that you might want to look at. Statins reduce your exercise capacity and deplete your body of essential CoQ10. Your exercising will be less effective. Muscle pains, may make it so that you're not able to exercise. You also may end up with shortness of breath, and mitochondrial damage occurs from statins. So all these things will work against your being able to exercise as well. Another point I want to make is that most patients on statins, between 90 and 99% of patients, do see a reduction in LDL. The reduction in LDL is the supposed benefit of statins, even though it only achieves a 20% or 9% relative risk reduction, rather than the 90 to 99% of the people who actually see a reduction in LDL. What this means is most of the reduction in LDL that patients get from statins does not result in any benefit. Now, it would be unfair to expect that because of this reduction in LDL that it would give us the 90% benefit if LDL were really a problem. It can be. I'll get to that in a moment. Because after all, if you are taking statins for secondary prevention, a lot of damage has already been done, and it's kind of hard to undo that completely. So for my closing thoughts, your doctor will never present statistics to you in this way. And if you're told that, well, you benefit anyway from having lower cholesterol levels, even if there's only a small statistical reduction in heart attacks, you have my permission to call them out and throw the BS flag on them. If lower cholesterol is supposed to be healthier and you still have a heart attack, then the healthier level is a distinction without a difference. The medical profession even tells us that high cholesterol is a hidden disease because there's no symptoms until you actually have a heart attack. Well, if you don't have one, then what is the health harm if there are no other symptoms? Now, yes, sometimes high cholesterol does have some other symptoms. They're rare, but they do occur. Xanthoma is one of them that I can think of. But in general, the supposed harm of the high cholesterol is on your heart health as reflected in a cardiovascular event of some kind. What counts is not the quantity, but the quality of your lipids. Poor lipid results such as oxidized LDL, pattern B, low HDL, high trigs, high VLDL, or high remnant cholesterol, these do indicate poor health. And if your cholesterol is of poor quality, then I guess higher is worse in that case. Don't be fooled by the overly simplistic HDL is good, LDL is bad paradigm. It's much more complicated than that. Some doctors believe that it's not even the cholesterol lowering from statins that results in those small statistical benefits, but rather anti-inflammatory effects. In that case, lowered cholesterol may be considered a side effect of the medication. Whether that is a good thing or a bad thing goes back to the question of your lipid panel quality. In any case, whether or not you take statins should be based on your getting complete information on what the statistics really show us, and most importantly, knowing that they do not offer that full protection or anything close to it like you might be led to believe. So that's what I've got on this topic. If you appreciate this content, please like, share, subscribe, and comment on this or other topics you'd like me to cover. And if you haven't seen this video, I recommend you take a look at it now. Thanks for listening.